I'm Sanjeev Bala, and I'm the Section Chief of Cardiothoracic Imaging here at WashU in St. Louis, Missouri. So one of the questions that always comes up is when to use MR. I think MR is kind of like that party that we've all heard about that we're going to be invited to, and one day we're going to be invited to come to the party. And we've been hearing about MR for, I think, decades as being a one-stop shop for imaging in the chest. In 2020, what we've realized is that MRI has some value, but its value is more of a problem solver for CTs where there's a question. As a primary modality, unless you're in a center of extreme expertise, it really is not something to rely on. And that comes from a lot of reasons. First of all, it's a longer study. A chest CT can usually be done in 5 minutes. A chest MR will take upwards of 30 to 45 minutes. Harder to schedule. Patients are claustrophobic. So we tend to use MR in our practice if we are confronted with mediastinal masses in particular, and there's a good chance the mediastinal mass is benign. Then the thought is that maybe you can do an MRI, you can kind of demonstrate that it's benign, and then you can stop the workup and not have to do something more invasive. We also find that MR can have some value if you're trying to figure out where to biopsy a lesion. Occasionally, a condition like Hodgkin lymphoma will be very collagen rich, and you'll do a biopsy, and the biopsy will come back saying that it's positive for fibrosing mediastinitis. And you'll look at the images and say, that doesn't really match. Let's do either a PET CT or an MRI so we can see where the areas of enhancement or uptake are greatest, and then we'll target that for biopsy. And then that can be very, very helpful. Another thing that can be useful in our practice has been that if we're looking at filling defect in an artery and there's a question whether it's a tumor, then either PET or MR can be very useful for making that distinction. And for soft tissue involvement, sometimes it's very useful to get a sense. There's some newer techniques that we're using. One of the techniques that we've done on occasion has been in people who, if there's a question, if there's invasion of an organ, you can have the patient breathe during the MR. And if you can see the tumor sliding against the organ, then you know that it's likely not invaded. And that's something that we're using increasingly for evaluation. But today, MRI is still pretty much a problem solver when we're dealing with thoracic conditions. And I think it really is based on the length of the examination and the potential for artifacts.